This meeting is being recorded.
Okay, as you guys all heard. Peter, how are you? Dr. Pobilski, how are you? Anyhow, it's a pleasure to have you all here.
I'm good.
Excellent. I think we've really been, I'd say, fortunate. We've had, a lot of very stimulating presentations and discussions on our forum here. Tonight, I would say, is even, I believe, going to be even more stimulating, as it's something that's critically important as we evolve as surgeons. We're operating on sicker people, older people. America's population is aging, and tonight I'd say we're really very honored to have someone who I think is one of the preeminent authorities on frailty screening and prehabilitation. I was lucky to meet Dan when he agreed to participate in a panel discussion with the college, and he's nothing short of just amazing. I think the work that goes into this is a great deal. It takes a great deal of thought and effort. Dan is a professor of surgery and anesthesiology and perioperative medicine and medical director of high risk populations and outcomes at the Wolff Center at UPMC. He runs the core faculty Center for Bioethics and Health Law at the University of Pittsburgh. Dan is a general surgeon with training in health services research, quality improvements, moral philosophy, and theology. I think Dan is an actual minister, which is really cool and unique. His work aims to develop reliable systems of healthcare delivery that are both technically excellent and directed towards the normative good of human flourishing. And that sentence says it all, in my opinion. Finally, his specific interests include measurements and mitigation of surgical frailty, long-term loss of independence after surgery, shared decision-making, medical ethics, and the formation of virtues necessary for the practice of good medicine. Dan is, a national and if not international authority on frailty and preconditioning, and we are very lucky to have him here with us tonight. I thought we would depart from our usual, where we have one of the junior members give a summation and review of a paper, given the opportunity to have someone of Dan's stature present to us tonight. So without further ado, Dr. Dan Hall, thank you very much for gracing us this evening.
Great. Well, thank you for that introduction, and thanks all for being here. I'm sorry that the manuscript as it was delivered didn't give you all that much time to review. Let me share my slides here. I think you should be seeing that now. Can I get some confirmation of that fact, Carlos?
Yes, sir.
Good. Cool. So what I'm wanting to talk about today is this user guide draft that I sent you all. That is, and let me tell you a little bit more about it. As Carlos said, I've developed a tool for screening for frailty and deployed it in probably 60, 70 medical centers across the nation, much in the VA, but also in the private sector too. That's not precisely what we're going to be talking about, but that work in July, there's going to be I learned in January that the National Quality Forum and the Joint Commission jointly together make an annual award called the John M. Eisenberg Award for Patient Safety and Quality. It's kind of like the Kennedy Center Awards for policy wonks in healthcare. And there is going to be a green room in Washington, D.C. in July. Dua Lipa and Mick Jagger will not be in that green room, but there will be a green room, and we'll see how all that goes. And what came along with that was a solicited article from the Joint Commission Journal on Patient Safety and Quality, of which there actually have been two that I've been working on. One to sort of describe the surgical pause as a program, but the other one to describe the Risk Analysis Index of Frailty, which is the tool on which it is predicated. all of this work has sort of come together in just the last 10 years pretty rapidly. Everything that I'll be presenting here is published in different areas, but no place did it have sort of a single source of information where you could go and put all of this together. And that's what I'm trying to do in this manuscript, and really am wondering and hoping if you can give me some feedback about whether or not I achieved that for you all. And I think I'll sort of stop there, not to necessarily put people on the spot, but if there are those who do have feedback at this point, before I sort of try to present the substance of the material that's within that manuscript, that would be a great place to start. And I have a pen on which I can take some notes. Does anybody have feedback at this early juncture?
This is Frank Podbilski. We use the Frailty tool on a daily basis at the VA. And, the only thing as a chest surgeon that I notice is sometimes as soon as you hook a cancer diagnosis to somebody, even if it's an early stage malignancy that, is found on a low dose CT scan, their frailty index. And I'm not sure we got our arms around how to compensate for somebody with pancreatic cancer who's already jaundiced and lost weight versus somebody who's got an early stage 2-centimeter nodule in their lung incidentally discovered, and how to sift that out in terms of the frailty tool. Do you have any thoughts on that?
I do. There's a paper actually that I can refer you to, and I'll show you a little bit of the data on that in some of the remarks in the slides that come along about how we're approaching that in a variety of different places. Any feedback specific to the manuscript that was distributed? If none of you had a chance to read it, that's fine. In which case, if I know that, I can just sort of move on to a presentation of the data.
Yeah, let's move forward, and that'll stimulate some.
Very good. All right. So to sort of orient things going forward, this is a graph from a paper published 14 years ago by McCary that shows the way in which frailty has a broader and larger receiver operator characteristic than something like the ASA score or the Eagle criteria. And when I started getting into this about a decade ago, the evidence was beginning to come together that demonstrates that frailty is perhaps the best predictor of post-operative outcomes, really, no matter how you measure it with regard to mortality, complications, failure to rescue, length of stay, readmission, loss of independence. No matter what outcome you want to look at, frailty ends up wanting to try to, or being able to predict it better than most of the tools that we have. So why is that? Then the question in orientation is what is a conceptualization of frailty? So I'm going to give you the one that I use and operationalize. Frailty is a clinical syndrome of decreased physiologic reserve that sort of you have the maximal amount when you are born and you consume it over the period of your life. And as you consume it, it's a process whereby small deficits accumulate in multiple adaptive systems, any one of which might be clinically insignificant. So they got a little COPD, they got a little renal insufficiency. You wouldn't be terribly concerned about the values of those in isolation, but together they produce significant vulnerability to stress that can lead to catastrophic decompensation in the setting of a stressor like surgery. It has multiple causes and contributors characterized by diminished strength, endurance, nutrition, and cognitive capacity. It is more than just the sum of age and comorbidities. It has a tendency to look at functional performance. And by looking at functional performance, what I mean by that is it will try to measure dyspnea rather than some other quantification of something like COPD. And by looking at the functioning of the organism as a whole, it does a better job of integrating the area under the curve of the sort of Humpty Dumpty divided all of the organ systems back together again. And frailty does a good job of pulling it all together. And it can explain why an older, comparatively more robust person, represented by this green line, is able to withstand the stress of exactly the same surgery that a younger, more frail patient would not be able to withstand, and they would die or have remarkably bad complications. Now, that's the definition that I use. But I want to be very clear, and you all should understand that there is no consensus regarding frailty. Those who are involved in it, it's kind of like pornography in the 1980s. Everybody know, all the people know what it is when they see it, but they can't actually define it to legislate it about it. There is consensus that it contains 6 domains: physical performance, gait, speed, mobility, nutrition status, mental health, and cognition. But there's no gold standard other than a 90-minute interview with a trained geriatrician called a comprehensive assessment. And because of all of that, it's led to the context in which there's just been an absolute proliferation of available measures, a cottage industry, everybody making their own frailty measure. Some of them have something valuable to add, some of them not. But a few years ago, Walston at an NIH consensus panel pulled together and sort of said, look, let's stop the arms race. Here are the 2 main ways that frailty is conceived. One is Linda Fried from Hopkins' physical frailty approach, which focuses on measuring functional performance in the form of a grip dynamometer, so grip strength, gait speed, weight loss, energy level, and the sort of quantified in kilocalories per week, the number of how much physical activity you have. This is great in a whole host of ways, used in a lot of research contexts, but it's got a high burden of measurement because it requires that specialty equipment in a fair amount of time. But it's one major way of conceptualizing frailty. The second main competing way is what Ken Rockwood did in the Canadian study on health and aging, which he calls the cumulative deficit model of frailty. He looked within that large registry of 500 variables and picked out 70 that had some conceptual relationship with the concept of frailty, and then developed an index where you would look at how many of those 70 variables any individual has, divide by 70, and you get an index between 0 and 1 representing how frail someone might be. He did further work to sort of show that really you don't get much more precision beyond 12 to 15 variables. And that sort of gave license for people to sort of start picking their own 12 to 15 variables and making a whole bunch of different frailty indices in precisely that way of looking at things. And they concluded by saying, look, we need to stop fighting over the definition of frailty and instead get about the business of doing something about it. So unless you have an unmet clinical need, really choose something off the shelf and not do anything further, right? So that's my general orientation to the way in which frailty is conceptualized. The other thing is that when you start to look and compare, this is some work that we did a couple of years ago with a colleague of yours up at Harvard, Ariela Orkaby. When you start to compare different frailty indices, and these are all frailty indices in the Rockwood model that are computed from ICD-10 codes, from administrative data records, right? And what you can see is that each of them have a different conceptual model. They're looking at different kinds of parameters to make up their frailty index. And these have to do with some of the differences in the frailty. But differences in the view of what frailty could include. But if you include in all of them age, which everyone should have, and you include sex, and you include some measure of their past utilization in the near period, in the last year of time, that's this sort of bottom line here, bottom row here, they all essentially have the identical discrimination. This is a C statistic, or the area under the curve, right? Suggesting again that it doesn't matter so much which frailty index you use, as long as you use one to try to, again, begin to do something and move things forward. and have some understanding of the conceptual framework of the particular model so that you can interpret things. So, but there's something to be clear, something interesting about this. Although they all have the same discrimination and they have the similar sort of positive and negative predictive value, and they would all, you could set a cut point that would identify the highest risk 10 or 15% of patients. They are not identifying the same 10 or 15 patients. This flower part is a very sort of complicated Venn diagram that shows the intersection between these five. All of them are sort of set at the highest risk 15% of the patients. So you can see that there is general consensus. And if you might think about the five blind men feeling the elephant in the room of frailty, many of them are in fact feeling and identifying the same general idea, but some of them are off in a corner and perhaps not feeling quite what it is that we're getting at going forward. So this begs the whole question, in my point of view, of which is the best frailty index. And my answer to that is that the best one is the one that you have. The one that you have at the bedside, ready to inform the decision-making when you need to make that decision. But in addition to being available at the bedside, it also has to be high quality and conceptually sound. For that reason, one of the things that shows up in a lot of the surgical literature is the modified frailty index, or the MFI, which Vilanovich and colleagues put together about 7 or 8 years ago. The problem with that one is that even in the full 11 items that it includes, it doesn't have a whole lot of focus on functional performance. It ends up being more like just a Charlson or a Elixhauser comorbidity measure. Furthermore, 6 of the 11 variables were sunset by the ACS NSQIP and are no longer being tracked. So it really only has 5 variables, which is not enough. Its discrimination goes down. And for all intents and purposes, although people continue to churn out papers on it, I think it's functionally obsolete and should be abandoned. For something that's better, I'm going to make the argument that the risk analysis index is that better option. But nonetheless, that's where things are. So the risk analysis index, which is the tool that we've developed, is conceptually sound in the deficit accumulation model of frailty. It is now the most thoroughly validated measure of surgical frailty available on the planet. But critically, it is also the only one that has been proven feasible at the bedside in a median 30 seconds of administration that some of you have experience with. The other advantage to it, in my mind, is that it is available in a suite of tools that operationalize the same conceptual model for application in different locations and data sets. You're familiar with the patient-facing survey that can be done at the bedside in real time, but the same conceptual model is mapped to VA SQIP and ACS NSQIP, and we just published a month ago a version of it that's keyed to the ICD-10 codes. So depending whether you've got registry data, whether you've got administrative diagnosis data, or whether you are trying to do it in real time going forward, you can use the same tool, and then you can sort of leap back and forth to gain inferences from what you're doing in quality improvement, go and test that out in a surgical registry, or use it in ICD-10s in your administrative data back and forth. These are the advantages that I see of the risk analysis index. It has 14 variables. It's scored unlike the Rockwood approach on, in fact, a weighted scale, and that has something to do with your question about cancer, which we'll get to in a second. It includes age, sex, living location, weight loss, and appetite. Those are 2 separate variables. 1 variable for cognitive decline, activities of daily living in 4 dimensions, and then a measure for congestive heart failure, the presence of chronic renal insufficiency, dyspnea, and cancer status. It has its most power if it's used on the quasi-linear scale from 0 to 82, which is the bottom and the top of its scale. But for interpretation, it's often easier to divide it into 4 strata, which we name as robust, average, frail, and very frail. Again, these have been, this approach has been validated in a whole bunch of different places and is the most validated along the way. Now, let me sort of show you how it's operationalized. Got to think about how I'm going to do this. There we go. I'm going to share this with us. And this is from the spreadsheet that was there before. So I said it had 14 variables, and it was conceptualized in a variety of different ways. So the RAIC in this column is the patient-facing survey. The RAIA is the one that's been mapped to ACS, NSQIP, and to VASQIP. The RAICD is self-explanatory. It's also been mapped to the Vascular Quality Initiative, which has its own set of variables. It's similar to ACS, NSQIP, but not exactly the same. So what you can see here is that we've got a, let me try to get this a little further over to the, can I move it to the right? Yeah, there we go. So we have the variable of age with a definition. This is how it's defined in the patient-facing questionnaire, and then these are the variables that would be used from the various registries. So what you can see here is that cancer in the survey is very broad, right? Is in the past 5 years, have you been diagnosed with or treated for cancer, right? You know, could that be, that could be completely in remission. That could be bad metastatic disease. That could be something that has just been newly diagnosed and is an early right-sided colon cancer and is likely to go really well, right? Its definition within the ACS NSQIP is much more constrained. Do you have disseminated cancer, or do you have a history in the 3 months before surgery of having chemo or radiotherapy, neoadjuvant therapy? That's what those 3 variables are, right? And it maps to a range of diagnoses in the ICD-10, which correspond to a 5-year mortality of north of 67%. So it is the more extreme tumor biologies that are there in that definition moving forward, right? So again, I'll refer this to you as well, but just showing to you how it's operationalized with the same set of ideas and variables within different contexts. Make sense? Questions on that? So we'll go back to this, and then can I do, good. The scoring paradigm. This is, again, what we wanted to talk about. Okay, so again, for the RAI survey, the RAI in the ACS NSQIP, the VQI, and the ICD, what you see is that age is scored as a statistical interaction with the presence of cancer. So within the survey, if you don't have cancer and you're 19 or younger, you get no points for that. But if you got cancer, you get 28 points as a young person, right? And you'll notice that the impact of cancer, look at someone who's 100 plus, you get 34 of a total maximum of 37 just for being 100 years old. And the additive risk of the cancer diagnosis in someone who's made it to 100 years is not nearly as impactful. But if you're 19 and you got cancer, well, this is a bad sign for your near-term mortality going forward. So it's disproportionately penalizing there going forward. And this, I think, Frank, it was you that asked this question, right? So you can see, particularly if a threshold for frailty is 37 on this score, you don't need many more. You just have to have one more risk factors and the presence of cancer to trigger above that frailty score to move things forward. So this really does drive a lot of the score. You've got, again, additional points for male sex, weight loss, appetite, renal failure, dyspnea, not a whole lot for living in a nursing home, not a whole lot for the renal stuff. And then ADLs and cognitive decline are also scored in a statistical interaction with each other moving forward. And we've mirrored that in the variety of different ways that have been going forward there. Now, to answer your question, Frank, what we do, and as you see in the VA, when the surveyor or the patient or the clinician fills out the RAI score indicating the presence of surgery, we will surface for you two scores. We will surface for you the score, the RAI score, which includes those points added for cancer. But we will also show you the score as if there was no cancer. And if it is just the cancer diagnosis that is making somebody frail, that means you have to put on your big boy pants and be the good doctor that you are all of this long and use your clinical judgment, right? We're just trying to give you all of the information that is there. If with or without cancer, they've got an RAI value that is above 37 or close to that threshold, this is a very strong signal to consider backing away slowly, right? But if they go to a very low score and it's just only the cancer that's adding that, you begin to sort of have to ask yourself what would be going on. And we've done some studies that have yet to be published, but I'm going to summarize for you those results.
So Dan, someone, Peter Mazzaglia asks sort of a similar question.
Yeah.
And I think it's pretty relevant. His question is, are there cancers that don't impact the score like this? And I think, a good, his question includes such as thyroid cancer, right, which is fairly indolent. And so I guess I would add to that, how would it compare if you had someone with cholangiocarcinoma versus a thyroid cancer?
Right. So it's interesting. I'm pointing at the RAI ICD, and I told you that the range of diagnosis codes for cancer from C77 to 379, that corresponds to those tumor types, tumor biology types, with a overall 5-year survival of, sorry, I said it the wrong way, of less than 33%, right? So you have a high risk of dying. That is esophageal cancer. That is cholangiocarcinoma. That is pancreatic adenocarcinoma, all those things. So it's the more severe types. We ran it 3 different ways, though, with severe cancer, moderate cancer, and mild cancer. Mild cancer would be the thyroid there, right? So, and we set those cut points at 0 to 33, 34 to 66, and more than 67% likelihood of survival going forward. Very small changes in the parameter estimates. We also have just completed, but I'm working to publish, a test of the calibration of the prospective survey version within about 500,000 assessments at UPMC. And that is when the patient asks the question or answers the question, have you had any cancer in the last 5 years? So super broad, super sensitive. All of those mild cancers like thyroid are going to get swept up along with the cholangiocarcinoma together. And I was almost certain that when we recalibrated it, this age, the age cancer interaction would compress. We would not be adding as many points to it. It didn't change a single integer value at all when we opened that up, right? So even in the setting of all that noise, cancer in all of its settings continues to add this, to indicate this strong risk for near-term mortality at 180 days post-op. Still need to use your clinical judgment, because when we look, again, if we stratify these scores of people who have similar scores or all have cancer, tumor biology wins the day. So everyone with an RAI score greater than 37, but you divide them by tumor biology with the thyroid cancers, the frailty score continues to stratify their survival, right? And those with high frailty and thyroid cancer, the frail people will die at a more rapid rate over time. And we can show you those survival curves, but they're all clustered up on the top of the graph the way that thyroid cancer does. And all the cholangiocarcinoma and pancreatic cancer is down at the bottom. So what does this mean clinically? It means that when you know about the clinical biology of the tumor that's there, and you think the patient has a decent chance of being cured by the surgery that you have, and it's the only thing that seems to be making them frail on this score, go right ahead and give them that surgery, which is likely to prove a benefit. But if they've got node positive pancreatic adenocarcinoma and their RAI score is 53, you're probably going to give them neoadjuvant chemotherapy first, and they're probably not going to do terribly well with that because they're frail already and don't have a whole lot of physiologic reserve to go forward with that. So again, it's a signal, but it's not determinative of how to treat these kinds of patients. Frank, does that answer your question?
Yes, and I think sometimes the chemotherapy and radiation serves as a stratifier for how people are going to do well anyway. So, but no, that's very helpful. Thanks.
Great. Some of that is in fact written up. Go ahead.
So, there's another question from Ira Leeds, and so I guess to sort of paraphrase this question, are there biological entities such as a burned out chronic diverticulitis that may affect frailty more than someone with an early stage sigmoid cancer, to which he says he can paint a far rosier picture? So in one case, cancer, and in the other case, a biologically aggressive disease like burned out chronic diverticulitis.
Diverticulitis, yeah. Again, that's a great question. And I have a fantastic data set now within the VA with 500,000 patients that has been linked up to just about everything else, VASQUIP and everything else in the CDW, where that particular kind of question could be asked. So if you want to reach out to me, and we can figure out a way to sort it. I don't have a clear answer for that in this notion, but it does. It impacts things differently in different clinical contexts. That's for sure. With regard to your subspecialties, we have published some papers. Like some of the initial feedback that we got is, of course, frailty is important for that crazy vascular surgeon who's doing those big open abdominal aneurysms, or that crazy thoracic or pancreatic surgeon. But I can get anybody through a gallbladder operation, or I can get anybody through a joint arthroscopy or a quick knee replacement. When you compare within subspecialties, this is published in JAMA Surgery, frailty dominates just about everything else. People who are frail or very frail have an order of magnitude higher mortality, such that 1 in 3 patients on whom we do an inguinal herniorrhaphy on are dead if they're very frail within 6 months of the operation. And this same pattern is observed in every subspecialty. In some ways, it might even be more important for comparatively lower risk specialties like orthopedics, because they're used to their eyeball test is not as well attuned as a vascular surgeon's to identify the frail patient, and therefore they might get lulled into thinking that oh, great, here's just another IM nail, I'm going to do another IM nail, and boy, do things go badly. They don't see it. The prevalence of frailty within the orthopedic segment of data sets is not nearly as high because they're operating on more robust folks. But when they operate on frail folks, things do not go well. All right. Does that answer your question, Ira?
It does. It does. I think that, your interesting point about the eyeball test is actually really interesting here, because I think that's kind of what my mind was going to, which is
Yeah.
that, and I'd love to talk to you more, and obviously we will, but, I love the RAI. You guys should really be congratulated for just how easy you made it for us. But at the same time, and I think, the prior comment suggested this too, is that sometimes it doesn't feel as consistent with my eyeball test. And we could, we could do some couch time where you explain to me how my eyeball test probably isn't perfect.
No, so again, the way that I think about this is that I think that frailty screening is really kind of like HIV screening is a two-step process. The first step needs to be systematized and made so easy that you can do it on everyone, right? And that's what the RAI serves. But it's not so much the confirmatory diagnosis. It's like, hey, wake up your eyeball and give a really hairy look at this one, right? And if your eyeball sort of says, nah, nothing here, or if you given the eyeball test and you follow up with some of the more resource intensive tests for frailty, like doing the grip dynamometer and the walking test and the timed up and go and the short physical performance battery, and send them to a multidisciplinary clinic. And after you can't do that for everybody, but once you've sort of done all of that, if it's like, sorry, this was a false positive, go right ahead. Or if for example, the RAI doesn't have anything to sort of scrutinize for end-stage liver disease and cirrhosis, right, which we know is devastating. So if the RAI seems to be low and you see the guy with a big belly with all sorts of ascites and a shriveled up walnut for a liver on CT scan, and your eyeball test is going, pay attention to your eyeball test. You've been a doctor for a good long time, and you know lots of things that this simple test is not going to be able to do for all things. So we're not looking for perfect. We're looking for good enough to take the first slice of the screening going forward. Right? So what I'm showing here is some of the validation in the VA SQIP and the ACS NISQIP. What you see in the red line is the predicted mortality across the range of the RAI score. In the blue dots with the whiskers, you see the observed mortality and the confidence interval around it with a C statistic on either side. This is for the one that's calculated from the SQIP variables. What you see here is that the model is extraordinarily well calibrated up to predicted and observed mortality of 40%, right? And that I'll show you in another slide in a little bit, that accounts for more than 90% of the patients that are there. Confidence intervals get wide at the upper scale because there are not many of these patients. The sample size is very low when you get up there. And although the model does have a tendency to overpredict what is observed, it's not like these patients have a low mortality. I think that this is, again, this is good enough to counsel patients to suggest that if it's at these upper ranges where the mortality rate starts to climb into, even fractions of a whole, it's the kind of thing that a patient and a surgeon would want to step back and discuss going forward. Let me get there we are here, move it this forward. This is a similar calibration curve that is done from the prospective survey version of the score, slightly less discrimination in a C statistic, and slightly less discrimination. But there's one thing here that I really want to point out. Notice that I've paid a little fast and loose with the y-axis, right? The lowest that it gets is 70% 2-year survival. And we do operate on even the most frail patients that are there. So again, using clinical judgment, we can do a better job than the RAI of selecting those patients who may still warrant and benefit from surgery moving forward. So never a thumbs up, thumbs down, just simply a notion to, hey, get out of rapid algorithmic thinking and be more deliberative for this person. So Again, I'm going to go back to this. Here is a summation of the model performance across all of the different kinds, the RAIA, the RAIC, the ICD, which again, within these strata will show you what a predicted mortality is at 30 and 90 days, what its sensitivity, specificity, positive and negative predictive value. We're still working on trying to come up with the F1 and the MCC for some of the tools. We've got that for the RAI ICD in place. Key points here would suggest that at the levels that we're using, it is only modestly sensitive, right, but highly specific. That means that if they score robust or normal, you can reliably move on to surgery, and they should achieve outcomes similar to those that are published. If it scores positive, it's just the first signal that you need to then confirm because it's only modestly sensitive with positive and negative predictive value going forward. Right. So with that, let me just sort of move forward a little bit more. As you've seen, either on an online tool or what we find to be best is to actually physically hand a single-side page of paper to the patient as they come in and are sitting in the waiting room. They inscribe what they think their answers are. There's noise involved with that. That's fine. They get roomed. Medical assistant, nurse, or resident or clinician can then sort of verify those responses. Probe them if if the patient seems to be demented and they say there's no cognitive decline, you can certainly override that and use your clinical judgment moving forward. And then key it into an online tool to do the calculation because those statistical interactions are a little bit complicated. The black line represents our experience at UPMC that said within 3 months, we basically achieved across the entire 5-hospital system in which we did this, the goal of an 80% compliance rate with assessing the RAI in every patient coming to an outpatient surgery clinic. We know that this took 30 seconds of time. It did not disrupt clinic flow. So again, not a reason to avoid this. And we've done it more than 750,000 times to date. I can talk to you about it from the designer side, but I nearly fell off the table when I tore my Achilles a few years ago when the nurse handed me my own RAI score. And indeed, I had a higher score than the day prior, but happily we went on and fixed that, and I'm back in the squash court moving forward. It's been implemented in Epic, Cerner, CPRS. REDCap is the way that we originally stood it up, so you could just have a link and anybody could get their own within their own EHR, the data moving forward. Now, here are some of the other bits that I'm going to sort of dig into about the kind of critique. Some people will sort of say the RAI is too subjective. We want some biomarkers on with that. So we calculated a bunch of different ways, published this last year. The RAI itself, right? And we recalibrated it to improve it moving forward. Then you can add BMI, creatinine, this is hematocrit, albumin, all the blood markers and all the biomarkers together. BMI and creatinine do not statistically significantly improve it. This is, again, a sample of nearly 400,000, so there's no difference there. There is an improvement that's statistically significant, though largely due to the large sample size, by adding hematocrit and albumin independently or in collaboration with each other. But the question that I have is that really worth the effort? And we've argued that the juice is not worth the squeeze, because this is the original RAI. Again, this is the proportion of a surgical sample. That green 43%, 43% for blue, all very low, and then 10% and 2.9% for these upper ranges. This is its calibration without the biomarker. This is the calibration with the biomarker. All of the improvement is happening up in this high level going forward here, where it really doesn't matter whether we're a little bit closer to the predicted or not. The predicted and the observed is sort of blisteringly high. And if what you're trying to do is just predict someone who's at increased risk for a poor outcome, I'm not sure that it's worth delaying for getting the albumin or the hematocrit moving forward. This is some of that data that I showed you before about how, regardless of the operative stress of the procedure, whether it's an inguinal hernia or a carotid endarterectomy or one of the big procedures, when you're frail, which is the green line, or very frail, regardless across a physiologic stress 1 to 5, your outcomes are disproportionately worse than otherwise. And then here's the last stuff that's there, which is the recent, and this will be the first place to try to publish this. We've been using the RAI in large data models to be essentially a single variable control for patient level variation, right? Rather than sort of throwing in 15, 20, 30 different clinical variables to assess for patient variation, we throw in just the RAI, which itself is a composite variable. And this helps solve some of the problems with model fit that can occur when you're trying to cut the data set too many different ways and have too many variables in it. But we wanted to know whether that was really justified or not. And in predicting postoperative mortality, we gave a variety of different machine learning algorithms, a wide range of about 50 different variables and these are the ones that show up as the most predictive. And we were pleased, also a little bit surprised, that RAI score is more important than having a pre-existing serious condition like respiratory failure. That's PASC. It's more predictive than emergent or urgent case status. It is more predictive than being DNR. It is more predictive than the Gagny score, which is the best of the comorbidity indices like Charlson and Elix-Hauser. It's better than surgical frailty, and it's better than age on its own. And when you predict something, a new outcome ranking score that we've called the desirability of outcome ranking score, which sort of looks at all of the different postoperative complications that can occur and ranks them from ideal, which would be the textbook outcome, to death or long-term institutionalization, with a UTI being sort of a lower, a level 2, and death or a stroke being level 4 or 5. Again, the RAI score emerges as, again, the most predictive outcome. Going straight back to where we started, that this is further evidence that frailty, at least as conceptualized as the RAI, is among the best predictors of surgical outcomes. All of this, I think, means that you should do it tomorrow, every patient, every time, because if you've offered or discussed surgery before you've tried to assess whether or not someone is frail, it's very hard to get that horse back in the barn. You should do it tomorrow because at this threshold on the survey version of the RAI, it corresponds to the riskiest 10% of the population who have at least twice the rate of mortality, twice the rate of readmission, and twice the rate of long-term ICU stays. The other thing that I'll draw to your attention here is you have all of the data that I've discussed, as well as a bunch of others, a systematic review with the PubMed ID, an assessment of what kinds of things that they were, what RAI variant where they were looking at, what surgical specialty, what were their outcomes, looking at what their cohort and population was, what their main findings were of the 128 papers that have published something empirically about the RAI to date going forward. So again, trying to capture for everybody what is known at this juncture. I'll skip over that because I want to leave a little time for discussion that's less. I did. I got right to the end. Well, maybe I will show this then, because we've got half a second. Not a surprise. This is from Maine Medical Center, that RAI is associated with cost, but perhaps even more importantly, it's associated with net income, right? So the RAI has more length of stay, more total cost, and lower net income, because of course the DRG for whatever these surgeries are is fixed to the DRG, not to whether the patient's frail. And if they've got increased costs, then your net income is going to go down in these ways. And we've seen similar stuff. This has just been published in Annals of Surgery, actually. This is from UPMC's data. As you may know, UPMC operates a health insurance plan as well as a set of hospitals. So for about 50% of the patients that we see in our hospital, we self-insure. So we know exactly how much payment benefit allowance go out for those. So in this sample of folks on whom we were self-insuring, we know all of their expenditures for the year after a surgical treatment. And what you can see is that there's a 5% and 17% increase associated with frailty or being very frail. But that is not due to the inpatient surgical DRG, as I just told you. It's in fact due to increased utilization of more specialists, non-surgical specialists that come to the inpatient bedside when the wheels start to fall off, and a whole lot more post-acute care that they use moving forward. So again, interesting stuff. And with that, I will stop presenting and we can have more of a conversation. I hope that satisfied the request, Carlos. And again, I would really appreciate any feedback you have on the manuscript, because it's due, and I want to make it good.
That was amazing. Thank you so much, Dan. So I guess I will open it up first to all the individuals that are participating. Any specific questions for Dan?
So this is Giles, Carlos, and thank you again for setting this up. And Dan, that was really wonderful. I guess what I'm a surgical oncologist, and what I struggle with is everybody I see has cancer, and they're all older, and they all have other medical comorbidities, and and the situation is usually not good in the sense that they've got, I've operated on a number of people with pancreatic cancer over the years and so forth. But the question is, that I struggle with is, where do you draw the line at this? Even with your eyeball test, you can tell when you're sort of getting into trouble, and how do you counsel? And one of the variables that I have found in life is that many people aren't that afraid of dying, particularly. What they're really afraid of is winding up dependent in nursing homes and that sort of thing. And so finding a spot where the risk is acceptable is sort of where I struggle. What are your thoughts on that as you've gone through all of this? I really appreciated your talk. It was great.
Thank you. I've got a couple of thoughts about that. There's I'm not going to show it to you. I'll just describe it to you. But we, well, no, I'll see if I can. Let me see if I can find a version of it really quickly here. No, I don't want to waste our limited time doing that. I've been able to solve for trajectories of post-operative recovery. The overwhelming majority of people do recover, most of them very quickly, within 30 to 60 days. But there are two separate trajectories, one of which takes almost a year to recover after surgery. The other is relatively independent. They have increased utilization and increased dependence on hospitals in the months leading up to surgery. And then surgery is the occasion by which they lose independence. We know this clinically from the people that we take care of anecdotally, right? But this is the first statistical population-based description of that, right? And I agree with you that is often the thing that people fear more than dying on the table, right? Like, I'm ready to die on the table. It's like, I can't remember the last time someone died on a table. What's going to happen is we're going to get you off the table, and then you're going to be in the intensive care unit for 30 days, turning you into the Michelin Man and doing all sorts of stuff.
And then what
That's the way it's gonna go. That's the way it's gonna go. If it's gonna go badly, right? And I don't talk to him that way, but this is what we talk about beside each other. So the
Right.
way that I do that counseling, I really find Gretchen Schwartz's best case, worst case scenario planning effective. When you get a little practice with this, it really only takes you about 5 to 10 minutes to accomplish. But what you do, and if it's just a frailty score, it's someone in your clinic, right? Because you're cancer and they're older folks and they've got a limited mortality going forward. But okay, say you've got a predicted mortality of 20%, right? And the way in which they get there is going to be by decreasing debilitation, loss of independence, going to an ICU, and then dying, right? That's the way it's going to happen. You can sort of say, look, you've got this pancreas cancer, you're 82 years old, you've got 15 different comorbidities, and yeah, I think it's technically resectable, but we have a choice. And I'm worried, Mr. Jones, that no matter what we do, your life is never going to be the same. That's a headline that sort of says, oh, it's not UPMC's life-changing medicine. They're not going to put me in a helicopter, and fly me in, and somehow these people are going to be magic and make me 18 years old again and storming the beaches of Iwo Jima. That's not a realistic expectation. So a headline like that helps them get into a frame of mind of like, oh, I got a big choice. And then you start telling stories, because human beings, the scenario planning is the technique that best case, worst case is predicated on. It was developed for the generals of World War II, recognizing that the generals and all human beings are not computers, and we don't do well with statistics. We do really well with stories. So if you can tell a story of what someone's life is going to look like under the best case, the worst case, and then the most likely case of a surgical treatment or a less aggressive surgical treatment, pelvic exoneration versus diverting colostomy, or just neoadjuvant chemotherapy or adjuvant chemotherapy, palliative chemotherapy. You need to provide them a treatment choice, and then sort of say, under the best case, this is what it's going to look like. Under the worst case, you're not going to die on the table, but you probably end up in the ICU. And if things don't go absolutely perfectly, which they wouldn't, you develop renal insufficiency. You tell them a story of what that looks like, and their eyes are going to get big, and they're going to go, oh, I was worried that was a possibility. I really don't want that to happen, right? Now you've named the thing that they're afraid of that's in the back of the room, and you give them something to push off of. And then you sort of say, but, I think that under the most likely circumstance, it's going to be a little closer to the best or a little closer to the worst. And you tell them that story, giving them those possible futures to sort of say, given what I just told you about the way things might go down, what's important to you? And that is the question. That is the key question. My grandmother or my husband was in the ICU for 6 weeks. It was awful. I never really want to be that way. What can we do to maximize the chance that will never happen? Well, if she tells you that, that the answer to that question is, I'm going to keep the scalpel in the drawer and we're going to send you home someplace else, right? But telling those kinds of stories in the counsel, you're not predicting the future. You're not sort of saying you are or are not going to die. You're ranging out what would be likely or more or less likely under different circumstances as a way for them to start to give information and be deliberative with you, so that if you can then understand what's really important to them at this last season of their life, which of the 8 arrows in your quiver is most likely to hit that particular target. But that target has to be defined in a rich, thickly described way about, whether it's walking the dog or whether it's doing the crossword puzzle or whether it's seeing the grandchild for the last time. Those are achievable ends. Living for another 100 years is not. Right. So, or long-term survival, the kinds of outcomes that populate our literature are too thin to really inform these kinds of decisions. That's how I would. How does that sound?
That sounds great. And I mean, actually, that's what I do with slightly different verbiage than you do. But I guess to follow up on the question is there, the use of these scores, one thing one way might be to how can you make it go? Can you make it get better? Can you make the RAI get better? Or do you use it to risk adjust, a surgeon's statistics as to how they're doing when they're operating on these people? And is there a cut point at which you would argue that you should just not? And I can see when you're talking about an operation that's done to improve the quality of somebody's life, and you're likely to make it worse. But it gets harder in some of these other circumstances, I think. And so, how do you envision this being brought to bear, basically?
So there are two questions there. One, can you make it better? Of course, we could make it better, right? But you reach diminishing incremental improvement, right? It's an asymptotic thing. So we add a variable for albumin, or then we add a variable for cirrhosis. You're not going to improve. You're always going to have uncertainty, right? And that's what the practice of surgery is about, right?
I'm sorry, Dan. I didn't mean making the score better. I meant making
making the patient better. Yeah, right.
I guess my question is, don't they go hand in hand? Right? If you have a particular score so we can probably all agree that at the ends of the spectrum, there's going to be those patients that are, super fit and not frail, are going to have great scores, and those that have poor scores. And so we can agree that what the outcomes and decision processes are going to be for those patients. But what about those patients that are sort of in the middle of the bell-shaped curve who, like me, they don't exercise, they don't do anything. We're too big of wimps to tear an Achilles tendon like Dan is, but potentially there's something that can be done to mitigate their performance. And if they improve, does their RI improve? And what are the data behind that and the outcomes?
Yeah, right. That's you expressed it better than I, Carlos.
Okay. So you can make incremental improvements. That's another set of talks, right? So in as little as 4 weeks, which is the time that most people have to wait in any case between a decision for surgery and the resource becoming available in the hospital. Like, for example, you can increase people's gait speed, reduce it by, a couple, 0.1 meters per second. You can make their timed up and go, standing up, walking across the room, touching the door, coming back. This tests strength coordination, all sorts of things. You can knock that down by 2.3 seconds, which is a clinically meaningful improvement. The data are not quite yet clear to sort of translate that out. We haven't done enough studies to translate that out into actual clinical outcomes, but there's every reason to think that that would, in fact, help. The challenge, however, is Hall's first law of prehabilitation, which is couch potatoes at rest tend to remain couch potatoes at rest. Which, again, I don't mean to be disrespectful, but we had a hard time recruiting into our pilot people who were like actually frail. It was people who were more or less robust who were the ones that willing to set up and do home-based exercises going forward. You'd think that the frail would have the most benefit from participating in this, because like any sort of exercise training, just in a couple of weeks, you can build up a whole lot of reserve. But this is the challenge with implementation science. You could show that it really is going to work, but getting an actual human being to do it is an even greater challenge. Doesn't mean we shouldn't try. And Mike Engelsby's work with CMS and getting people to increase their step counts, again, is more for the predominantly robust who could train for a 5K, and you're just trying to get them to do it for the 5K that is their surgery, and they do better along those lines. But that's incremental improvement among the normal and robust population rather than among the frail. And I think that there are some fundamental problems with the exercise therapy. That doesn't suggest that we can't do substantial work with nutrition, which can be intervened on in between. The other exercise that I'm most bullish on is respiratory threshold therapy. I'm going to show you this thing. This is a threshold spirometer. You can see the little red line there and the spring, right? So you can set that to a particular, centimeters of water, or it's centimeters of water, a threshold above which you need to exceed if you are inhaling through this device or blowing out the other direction. And you can you can do PFTs and test what their volumes and pressures are. But rather than just doing inspiratory spirometry, which is just air exchange, this is resistance training for your intrinsic and extrinsic muscles of breathing. It is of the prehabilitation things, and this is pretty freaking easy to do, that you can do this sitting on your couch as a couch potato watching TV. And this has been shown to decrease pneumonia, respiratory, ventilator depression going forward. It's been hard pressed to get the hospitals to sign up for it. It's not expensive. It's $25. And you can have an add-on spirometer that can hook up to a tablet so that you could do this in clinics. It's a little bit more to accomplish, but this is, if I were to back a horse for prehabilitation, it would be this thing right here.
Okay.
So one question I would have is, I mean, so there was that paper by Schluter that demonstrated that 4 weeks of prehabilitation are very effective in, I think it was colorectal cancer patients. But the point that you've made about the fact that we can make incremental gains in people, in patients, is fabulous, right? And we can improve nutrition, we can improve some trivial exercises. We can, I even actually will talk to people about getting some simple puzzles that their kids would work on, or crossword puzzles. But the big issue comes down to cost, right? You've demonstrated that, how the RI correlates with cost, but how are we going to actually leverage medical systems? And I would put Dr. McEnany and all the leaders in the group, and to include, the UPMC group. How receptive is the C-suite to, actually implementing even things like what I call the paper bag approach to preconditioning, and we just give handouts to patients to things that they need to do. We talk about using things in your kitchen like, tomato soup cans and, water jugs and stuff, because at the end of the day, that Schluter paper was great, but they actually had a captive audience that had, I believe, in a hospital, training and different things like that. So how do we address the underinsured, served populations? And I know that's a tall question.
You want me to solve all the problems of American medicine right there?
I really do, but that's the whole thing. How do we apply? We've got a simple tool, but that's where the I'd say the rubber meets the road, right?
Yeah, I mean,
Because it's just underserved, but it's
I have flourished because there has been deep support from the C-suite at UPMC. Their financial picture has changed in the last post-COVID, and they're just trying to get their revenue sorted in a way that they haven't in their 30-year history. So there's a little less ability to play when they were booking, when the nonprofit was booking hundreds of millions of dollars of nonprofit year over year. It was easier for them to move some things around that's reversed the opposite direction. But I do think that there's an argument to be able to sort of say that, look, we're not asking for high-tech interventions, but we do need some support to be able to deliver these kinds of interventions. Unfortunately, I also think that there's part of the psychology of patients and our general healthcare marketplace is that we would rather have a high-tech, high-expense back-end intervention than intervening upstream simply with a gym membership, right? So,
but the springboard off of the question, the point that Carlos made with RAI. Two things in terms of hospital revenues. I mean, do you see this going where the hospital is going to look at individual surgeons and say, no, you're not operating on someone with an RAI of 60. This patient's uninsured, and we're not going to stand for this. Number one, and that's point number one. And point number two, because I go to M&M and I'm on the peer review committee, have you seen the RAI score kind of creep in as a putative point of criticism for the surgeon who says, well, I did the eyeball test. He seemed healthy. Yeah, his RAI was 50. You know, do we ding you at the VA because you elected to operate on somebody like that? Two kind of related questions.
All of those things are happening, right? So the initial demonstration paper from 2017 of the surgical pause, my colleague Jason Johning, who was chief of surgery at the Omaha VA at that time, made the RAI mandatory for booking a case in the OR. So you had to give it, and then he was doing a review above a particular threshold and picking up the phone and sort of saying, hey, what are you thinking? In some cases, like, are you crazy? Other times it's like, are you sure? Are you sure? And how can we make things better? And get people in place, right? It also has become in a variety of places part of the routine data array that's presented at M&M to sort of quantify that, and it becomes part of the conversation. It's about to become part of the quarterly reports that go out through the National Surgery Office to all of the surgical programs in the VA. So I think it can serve that notion. We've had discussions with the UPMC health plan. And I suspect now that the Joint Commission and National Quality Forum has recognized the surgical pause with the Eisenberg Award, that more insurance plans may begin to use it as part of their pre-authorization. We're not going to pre-authorize your case until you give us an RAI. And if the RAI is above a particular threshold in combination with some other things, you're going to have to do a pretty good job of persuading us why.
Additional pre-certification.
Yeah.
The question will be who actually then does the pre-authorization of that, right, Dan?
Yeah.
Will it be who has a sense of it, or will it just be another clerk saying we're not,
Which is why I've not been, we've been talking about this within UPMC, where I know the players, and it's not going to get completely out of control. I don't want to release that particular virus into the system before it's really ready to go.
Yeah.
So, yeah. All right, I need to go. I need to meet someone at 8 o'clock and be there. But thank you all for joining. Please do reach out.
Thank you.
Thank you so very much. That was amazing.
Fantastic.
You all have a wonderful evening. It's a pleasure seeing you all again.
Yeah, take care. Bye-bye.
Good night.